Good afternoon, everyone. Welcome to this session, and I'm very pleased to have an interesting panel where we will discuss issues around treatment and treatment success. So, in your, if you go to the Skiffer, you will have details of each of the panelists. So I'm not going to introduce them now. You could go and look for the details of each of us in the application. So I'm going to start straight into questions, and I'm going to start with Tsitsi. Tsitsi, you are working in the Ministry of Health. You have big responsibilities. So tell us how you go about, or what are the challenges for making decisions around service delivery and maintaining treatment access? What are the challenges that you face when you have to make those decisions?
Thank you very much, Ale. Thank you for the opportunity to be a panelist in this session. Zimbabwe is a high-burdened country in terms of HIV and AIDS, and there has been a lot of progress in terms of reducing the HIV incidence, and the scale-up of treatment has been phenomenal, particularly in the past few years when we started implementing Treat All. We have over 1 million patients, 1.1 million patients that are accessing treatment. So at some point we've been reflecting to say, okay, the numbers have increased so much, but it's not only about the numbers, but we have to make sure that we actually provide quality services to all those people living with HIV. So the greatest challenge that we have is the mismatch between the resources that we have and the burden of people that require continued quality services.
Lower that microphone a bit to your mouth.
Okay. So the greatest challenge that we have is that the funding levels have not increased to match with the needs in the country. And at some point we were reflecting and saying that because of the great progress that we've made, that actually opened up gaps in terms of treatment numbers. Just recently when we wrote the Global Fund application, we had ensured that we covered all our gaps, but there were emerging gaps almost just a few months down the line, even before we started implementing the grant. So we have issues to do with challenges in terms of monitoring patients on treatment. Our lab systems are not equipped enough to be able to provide to diagnose the monitoring tools, and we have the fact that we've decentralized our services all the way to primary care level, with over 80% of our patients at the lowest level. We need to ensure that standards are maintained at those levels. We've come up with some guidance, so operational and service delivery manual, which detail the minimum standards by level of care, just to help to improve the quality of services that are provided. But we see that policies and guidelines are in place, but the practice differs because of the challenges mainly to do with human resource challenges at the lowest level in particular, and other tools. Our data is also an issue. We need to track everyone that is on treatment. And the fact that HIV is incurable, we need to make sure that we are able to longitudinally track people living with HIV and establish their outcomes. So this has become a challenge. Okay. So this... Hello? Is it working? So we are, with the increase in the numbers of people living with HIV on treatment, the paper-based system that we use for recording and reporting of our data is not working.
It's not working. You get this. Number one.
So with, I think this sounds better. So the paper-based system for us to be able to record and report different events that occur along the pathway of care for people living with HIV doesn't seem to be working with the sheer numbers of people that need to be managed, particularly at the lowest level. Although there are efforts to put up electronic systems for at patient level, but these are still being rolled out, and therefore this is a constraint to our systems. The private sector is lagging behind. We spend a lot of time, effort, superintending over what happens within the public health sector. But we're seeing some malpractices where patients are failing treatment, having been referred from the private sector. And this is something that we need to really look into. And also, there has been a lot of movement of people across the borders, for labor purposes, and also internal migration of people, particularly in informal mining sector. So these present challenges in providing quality care because of the mobility of people that are on treatment. And therefore, we really need to think outside the box in terms of how we can provide quality services, particularly to this kind of community. Another challenge in terms of quality of services is within the prison settings, where they've got very high numbers of the prevalence of HIV is double that of the general population, and the infrastructure within prison settings is not conducive really for caring for people living with HIV. There's a lot of TB, HIV co-infections going on, and therefore these are areas that we really need to ensure that we provide support and improve the quality of services in those areas.
I'm gonna do a follow-up on something that you just said about funding. So how you go about making decisions around funding, and how you balance the needs between treatment, prevention, care. So how you go about.
I think this is one of the very. This is one of the very difficult questions, and for those that have participated in coming up with proposals for Global Fund, people always fight, just to decide where money goes where. Our greatest funders include the Global Fund, PEPFAR, but we also have a national trust fund. We generate some funding, and obviously from the government. The allocation of funding is really informed by the investment thinking, because we do have those investment case scenarios where we discuss interventions that have got the greatest impact, and that governs where resources are channeled. But in many instances, you find that the funding envelope is really not enough. Even just to think about the high impact interventions, it's just not enough. And therefore, it's a difficult situation. What we find is that know your epidemic, know your response has really helped us to target responses in those hotspots areas and the populations. And in a way, it helps us to sort of prioritize and focus on those specific areas. And also, but what we've seen is treatment programs tend to get the lion's share. Even from the National AIDS Trust Fund, 50% is earmarked for treatment. But even with that, you find that the treatment needs are getting bigger and bigger, with over 1.1 million people on treatment. And therefore, we feel like we're now being seen as people who are always presenting gaps, and yet it's really a result of the good performance of the program that now there are emerging gaps. And there's also always this ethical dilemma of deciding where to put the money. Treatment, you're faced with people, real people who are actually on treatment. And you want to make sure that you offer them multi-month prescriptions of drugs. And people are already excited about these changes within the service delivery approaches, where they get 3 monthly supplies of medicines. And now giving them weekly supplies or 2 weekly supplies because medicines are short. It's something that is very difficult. And therefore, many times we allocate more money on treatment, and then other programs tend to suffer, unfortunately. So we need to always think about how we can allocate to prevention interventions as well. Just recently, we launched the PrEP implementation plan, and certainly we do have ambitious targets to implement PrEP, but only 50% of commodities are being will be funded. Those are the commitments. And therefore, we do have gaps in prevention, and therefore, it's very difficult. What we need to do is to really find the money to cover all these gaps, because they are all critical. So that's the challenge that we're experiencing.
Thank you. I think you're placing a number of questions and issues that we will explore in more detail along the session. I'm going to turn now to Daouda and the experience in Senegal. And what would you say in the context of Senegal are the major challenges for ensuring quality of care, and who is missing out of the care system? Who are the missing ones?
Thank you very much. I think for the case of Senegal, first of all, Senegal is a low prevalence country with 0.7% for the general population, while we have a highly affected key population, sex workers, men having sex with men, IDU, as well as people living in prison. And then we have also area of vulnerability with area where there is a high mobility, cross-border mobility, and area where, because of mining activities has grown these last 10 years incredibly in Senegal. So who is missing? Clearly, those who are missing are those who are missing in getting access to testing. Because before you get to treatment, you have to get diagnosed. And those who less have access to treatment are key population, because they're facing many barriers. Within the health system, the level of stigma against key population is still very high. And then they're facing also a lot of discrimination at community level. And then we still have legal barriers. And let's say barriers that are related to ideology or religion that hinder even health professionals to deliver services for those key populations. And the other barrier that I see, and the challenge that I see, is the fact that there is, in the health system, there is still a kind of conservatism to strengthen the role of civil society in delivering treatment. So we are in, let's say, francophone, very conservative francophone health system oriented, where everything is centered in the health system against the community health system. So community health workers are not valued, even though when you see who is delivering services to population, it's mainly community health system that is delivering. So the missing the population are key population who are only served and treated in the community health system that is fighting to get a space within the system to health. This is one of the main challenges that we are facing in Senegal. The second is that Senegal is surrounded by many countries. A country like Gambia, a country of origin, the Gambia of Gambia, where the situation of key population is extremely severe, extremely. So what we managed to do is we set up cross-border program where we're waiting at Senegal's border. We're waiting people coming from Gambia and coming from Guinea-Bissau, because Guinea-Bissau has gone through a lot of conflict and political instability. So we are also receiving many people from cross-border who come also. And as non-Senegalese, they're facing a lot of challenges. What we're also seeing is that when people are put on treatment, They come regularly to health center for the first 6 months. And after the first 6 months, they start being missing. So, and then the current program don't fund significantly community workers to go and get people who are missing on treatment and to get them back to the treatment system. So this is also one of the challenges that we are facing. And when we engage with government on how to prioritize community intervention, how to prioritize and focus on providing treatment, testing and treatment for key population, we realize that providing services to key population itself is highly political. It's highly political, and it's also another battle that civil society are taking on in an environment that is not always conducive, and in an environment where civil society organizations who are bringing key population to the system and to treatment themselves are being fragile because they are receiving less funding. And their own organizations are being threatened when the funding decreases. When the funding decreases, the intervention that will cut first, the intervention for key population or for civil society. So these are challenges that we are facing in Senegal, but as I work in at least 15 countries in West Africa, that's exactly the same pattern that we're having in the other countries in the region.
So AIDS continue to be political, and will always be.
Absolutely political.
Yeah. I'm gonna turn now to Megan from WHO, and from WHO perspective, what type of guidance you provide to countries? And I will expand it a little bit more and say not only in terms of prioritizing resources, but also to address some of the challenges that Daouda and also Tsitsi mentioned. How you guide countries.
Okay, thank you very much for the question. And I think actually by expanding it to more how we guide countries is easier than the sort of helping countries with understanding and prioritizing and working through allocated resources, because I think that's the hard question. And I know that this came up in our conversations during the several meetings of, will we have enough money to finish the job? Will we be able to give high quality care to everybody who needs it? And if we can't, and if there's not enough money, what do we do? And in the WHO for the HIV treatment and care and also prevention, we've developed consolidated guidelines since 2013, which incorporates guidance and guidelines for testing, treatment, monitoring, et cetera, across the cascade. And in 2013, we had a chapter dedicated to actually how can program managers and programs start to prioritize. And I think it came back to some of the things that Tsitsi discussed very eloquently, is that it's based upon an investment case. And there are some principles that one needs to keep in mind, and certainly when one comes to taking a WHO guideline and trying to adapt and adopt all those things in that guideline. And I think in the 2013, well, at least I know in the 2016, we had something like 78 different recommendations. Will every country adapt all those recommendations? Highly unlikely. So therefore, there does need to be some level of understanding your epidemic, having an in-country process that brings communities, brings end users, brings healthcare workers, and also the budget, the finance folks around the table. And I believe the countries that seem to be doing it quite well also take some of those models that are available, maybe potentially generic models like the One Health or based on the goals model, where you can look at allocated resources. If you put them here, what will happen over there? What is the cost effectiveness of one intervention over another? And I think by interpreting those and doing them for the actual country that one's living in, I think that helps much better. And I think a great example is both from Zimbabwe. They have a model, as well as South Africa, where you can see for them it makes total sense to put as much money that they do into treatment, into TB, because at the end, if they don't, they know they will have to pay at the back end. So it's sometimes about making that argument as well. But on the other, I think, relation to quality of care, in 2016, we really took on the topic around differentiated models of services, and that sort of has had a life of its own. Now we have differentiated ART, differentiated testing, differentiation for prevention. And I think that's great because what it's just talking about is a public health approach does not have to be one size fits all, and that we can do more with community-based approaches, and we can do more, and that not every person needs to come back to the clinic every month or every 3 months, that they might be able, we can move to more of a self-management approach. However, with the idea that we free up more resources for those who are costing the healthcare system more, for those with advanced disease, et cetera. But I think what we have to keep in mind is those systems need monitoring systems, and that needs investment to be able to follow people over time. I think we also have other guidance as well available for key populations and addressing some of the structural barriers that I heard spoken about in Senegal, and certainly some of the issues for West and Central Africa about unlocking barriers to universal health coverage, because I think in many of these countries, people still have to pay for a lot of their health care. They may have to pay for their HIV health care, and that will be a barrier for us to reach the 90-90-90. So, yeah, we probably have if you ask us a topic, we probably have a guideline for that. So we recommend that you go to our website and take a look. Thanks.
Thank you. So something that is coming out in most of the conversation up to now is the issue around funding and where is the funding to be able to sustain the achievement made up to now. And I'm going to turn to Wame as an activist, as a civil society representative. The withdrawal of external funding, how that will affect, how you see affecting the quality of service delivery, and particularly, and linking to the points that Daouda was making, is how will affect also the community health systems.
Thank you very much. I think the very concept of withdrawal of external funding is a very hard pill to swallow at the moment. And that's because we recognize the hit that it will actually take to the systems that we currently have. External funding is really funding programs that either government are struggling to fund themselves or don't want to fund, because some of them are key population programs, for example, that really deal with communities that the governments right now are not resourcing or providing resources to. And the other side of that as well is that we see that governments are also really struggling to absorb the programs that are being funded by external funders. Even in countries that are doing very well in terms of increasing their domestic resources, there is still a struggle to absorb some of the activities or services that are being funded by external donors. That said, I think one of the concerns that we have as an overall is that we're not talking about quality enough. When we look at all the statistics and data that is being shared, like the 90-90-90, yesterday was some very beautiful statistics in terms of where we are, but we're not talking about the quality. What is happening to people who are in the system? What are the effects and issues that we're seeing within people who are actually accessing services? And from our perspective, it's a very difficult scenario that we're seeing. We're still seeing a lot of drug stockouts, which are creating other challenges. We're seeing services that are either not being, the uptake is still low, for example, RVLT, where it is being offered, or some instances where there isn't enough demand for the service, or the service is actually not being provided up to the quality that it should be. So, for example, routine viral load testing, we keep hearing that there are machines that are broken down, they're not available. We keep hearing about the turnaround time for tests being more than 6 months for a recipient of care to receive their results. We keep hearing about stockouts in terms of even lab reagents. So there's a lot of issues that we're still seeing, even within the current system that is being provided right right now. And these are all quality issues that we're not speaking of entirely or measuring either. So part of the concern that we have is, as we're scaling up, we're not actually measuring the quality of what we actually are doing at the moment. And we haven't created data systems in order to sort of track that over time. And this is a big part of some of the challenges that we have on the ground.
Thank you. And the issues around stockouts are resonated in my region as well, Latin America and the Caribbean. We see more often stockouts of drugs. So I'm going to turn it to Francois and follow with the issue around stockouts. How complex is the issue in South Africa? Is happening? How frequent? And what are the implications for quality of maintaining quality of care, service delivery?
So South Africa is a very complex place, and it's blessed and cursed with the fact that it's got a lot more money than its surrounding neighbours. It spends it very, very badly. It doesn't matter what metric you look at. It doesn't matter whether you look at health or education. I think it's one of the things I do worry about the funding discussions is that it doesn't buy you quality. We waste a huge amount of money. We have one of the least, until recently, one of the poorest performing TB programs on the continent. We spend more per TB patient than any other patient on the continent. We have one of the worst performing education systems, and we still spend more per kid than anybody else. So I think that we do find these quality metrics to actually hold governments accountable for poor performance. So I think finding those metrics is very, very important. I think with the things that I grapple with is I actually think HIV has taught us to find those metrics. I think the beauty of the HIV world is we have such good biological measures of quality. If you start 1,000 people on treatment and 900 of them on therapy 5 years later, and 90% of them have a viral load that's undetectable, you're doing a pretty good job. You know that the counselling is in place, the supply lines are in place. We've got a biological metric, and a denominator that really helps us do those measurements. What we haven't had is those measurements for many of the other diseases, and I think that the challenge is starting to fix the healthcare system by holding them accountable against that. What South Africa has been really interesting is we've had kind of these activist-type economists who've ascribed a cost to South Africa, and they've taken it to Treasury and said, this is what an HIV life costs. And Treasury, and initially it sounded like a massive number, but Treasury, economists like known risks, they don't like unknown risks. And they would look at this number and say, we can actually afford this. What we're finding difficult to swallow is we have no idea what a schizophrenic costs, what a malaria patient costs, what a diabetic patient costs. We're just pouring money into this black hole in health, and yet the returns on investment that we're getting from the TB program in particular is shocking. So I think the challenge is to take these lessons and these metrics that we've devised for HIV and start applying them across the healthcare system to start looking for those repairs. One of the other things we did was, just coming back to the drug stockouts thing, is take the lessons of drug stockouts, because we were 4 or 5 years ago, it was driving me crazy having phone calls from across the country about how the drug stockouts and the civil society groups, the MSFs and the TACs and the South African Clinician Society and Section 27 got their heads together and put out these stop stockouts projects, some of those slides you saw this morning. And what we've been able to demonstrate is working with government is to start showing that fixed dose combinations, we almost never stock them out. The fact that they're large volume, that there's enough crossover between the fixed dose combinations between the depots. The people who stocked out were the pediatrics patients. They were the patients on strange regimens, the patients on second line where there were singles in the system. And we had perpetual stockouts. And what that's meant is that when we construct guidelines, we focus very hard on trying to find as few reasons as possible to depart from the fixed dose combination. And explaining to clinicians that, having a fixed dose combination is life-saving for lots of people. And every time you deviate from that, for all the small groups of people that you might save their lives, there's also a substantial number of people who are now at risk of dying because they're not going to get their therapy because the supply lines are still so fragile. So I think there's a lot to learn, and I think a lot of the other aspects of the healthcare system needs to start learning from the HIV areas to find these markers that are of quality.
And you mentioned, and I'm going to do a follow-up, you mentioned the issue of trying to maintain the minimum sort of a regimen, not to have them very complex. And what is your take on introducing dolutegravir? Because that was sort of, and I know WHO is the recommendation, but now we come out with the issues around resistance and issues, sorry, not resistance, but the issues around pregnancy, dolutegravir during pregnancy. So what is your take on moving into a more unified regime?
So I think one of the things that we didn't realize with dolutegravir, and I think there's this idea that everyone could move to dolutegravir and it would solve every single problem in the world. A certain number of people would not be able to tolerate dolutegravir from the very beginning. There was always going to need to be an alternative. And to my mind, the only alternative that could be in the system until some of these other drugs come along is an efavirenz-based regimen. So it would be the old regimen. So we always were going to have two regimens in the system. I think the challenge now is to make sure that in the context of this neural tube defect, is that we're able to provide the sort of information to a woman to say, I think sometimes with, particularly doctors and nurses have this real problem with not saying, we just don't know. And that's the problem with dolutegravir in the context of pregnancy. We just don't know. We've got a worrying signal, but it's not confirmatory. It may be overturned. It may turn out to be real. What's wrong with saying to a woman, look, we need to be able to say to you, we're offering you this drug, but we have an alternative because we just don't know. And let them make that call. And I think that we're going to have to make our peace with that. I think the complexity is in places where you don't have contraception. And I think the thing that dolutegravir has shocked me about is how many countries do not have access to contraception, do not have safe access to termination of pregnancy, all the things which I think many people have just taken for granted. And I think it's an amazing advocacy opportunity now to say enough already, that one of the most effective forms of PMTCT is actually family planning. And why don't we start allying this issue, saying we want to roll out dolutegravir, but this needs to be attached at the hip with expanded access to contraception. You don't just get to treat a woman for her HIV, you have to look at her broader needs.
I hope there are more physicians like you, Francois, in the world. And one of the issues in terms of stockouts is clearly resistance. So if you could tell us, Meg, what have been the advance since the call for the global action? Yeah, the global action plan.
Okay, good. But I do want to say that I echo what Francois was saying, that out of this we do have potentially a silver lining that we actually have to work towards. And I do think that also the question around resistance complicates this discussion, because last year at the same meeting in Paris, we launched both a guideline about how to handle the increasing what we call pre-treatment drug resistance to efavirenz-based regimens. And at that point in time, the obvious answer was, well, we can use an integrase-based regimen, and which integrase-based regimen would be the most suitable? It was likely to be the dolutegravir regimen because of its other properties of being, it reduces the viral load. It seems to be having a high barrier to the virus developing resistance to it when used with other drugs. So it's also part of what we'll be presenting tomorrow, if I can do a shameless plug about of what WHO now believes for our next update for ARV guidelines and how we're going to handle dolutegravir. Learn more tomorrow. But going back to since the Global Action Plan on Drug Resistance was launched last year, and it was with Tobias, who's in the audience right now, who really took that forward and worked with Silvia Bertanolia from our WHO on this Global Action Plan. It had five pillars, and it really links into the whole AMR, or antimicrobial resistance sort of umbrella. As the WHO, perhaps this morning you heard about universal health coverage and working towards a more sort of integrated approach. The focus of the Global Action Plan was about prevention and response, and that would have been changing a regimen. It's about monitoring and surveillance and increasing the kinds of surveillance we're doing now for integrase inhibitors. Research and innovation, all these issues about how do we transition from an efavirenz regimen to a dolutegravir regimen? Do we need resistance testing? That research has to get done, as well as supporting lab capacity development and governance and advocacy. And I think since last year, there's been some movement, maybe not financially investments into drug resistance, but I think there's been more of a sense that drug resistance fits squarely in the treatment sphere where Before it was sort of in a special surveillance category. And with the Lange Institute, we had an advocacy meeting, and I think it's like all roads lead to quality. At the end of that meeting, the discussion was, what about quality? You know, it's not going to be resistance. It's not going to be the dolutegravir and the silver bullet. It's about how we deliver services. Are we worried and measuring for stockouts? Are we looking at 12-month viral load, 48-month viral load? Are we putting in the systems to be able to encourage and keep people who need to stay on treatment for a lifetime self-engaged in their treatment? And so I think we've done a lot, but there's more to be done in drug resistance. And I think in terms of now looking for will we have development of integrase inhibitor resistance, and we hope, you know, presumably we will eventually, but we need to be prepared. And we also, I think, need to start to address what we're seeing with children and adolescents, that this is sort of a crisis where we need to get in and get those better regimens, because we can presume that the kids and the adolescents probably do have resistant virus. But that we really need to work back on our early warning indicators of quality and come back to the issues of removing stockouts and ensuring that people are able to have access to viral load and the viral load is utilized to improve their care.
Thank you. I'm gonna pass now to Tsitsi and following on the issues around drug resistance. So what can you tell us about drug resistance in Zimbabwe, and how you go about addressing the issues in people who presented with resistance, but also on people like, for example, young people, adolescents of children that are resistant pre-treatment, before starting treatment?
Okay, thank you for that question. Zimbabwe has been implementing HIV drug resistance as part of its surveillance program for almost the last decade, really. And we adopted the global WHO strategy for drug resistance that looks at HIV-DR monitoring at 12 months, 24 months, etc. And also we embraced the pre-treatment drug resistance surveys, as well as the early warning indicators. So we've been implementing this to help us inform policy direction towards the choices for our first line, second line, not only mainly at global level, but also national level. So, so if you look at some of the data that is coming from the survey, the levels of resistance are fairly high. For example, the 2015 data shows that the levels of resistance for any drug was at 10.9%. And if you break it down, you find that most of the resistance is from NNRTIs. And our surveillance that we conducted, we also included participants that had been exposed to prior ARVs. And therefore, what we noticed was that women had a higher level of drug resistance, which was 4 times higher than that in men. It was 16.1% compared to 4% in men. And this is basically related to exposure to PMTCT program. I know other countries, they restricted their surveys to those that did not have prior exposure. So probably their patterns are different. But generally, there's a high level of pre-treatment resistance, and this is a cause for concern. Looking at the acquired HIV-DR in 2010, it was lower. It was around 3.5%. So we are concerned about these high levels of resistance, and we are having discussions around changing our first line towards DTG in recognition of these levels of resistance. And currently, our national ART guidelines recommend drug resistance testing for those that fail second line to inform choices of medicines for third line. But you find that very few patients are accessing drug resistance testing in country, and they can't afford. Within the public health system, we don't have this kind of service to inform individual patient care. And therefore, we are using it mainly at surveillance programs at that level. And basically, for those that are able to access drug resistance testing, then we use the findings to inform appropriate switches to third line. So the emphasis is really to prevent drug resistance. That's the focus of this strategy. And because when patients are not adhering to their treatment, when there's suboptimal adherence, then they're likely to acquire drug resistance. And then they transmit that to others. And then you end up with high levels of pretreatment drug resistance. And this is particularly worrisome in the test and treat era, where many people are they're asymptomatic. They haven't really been sick, and therefore issues to do with adherence to treatment is becoming an increasing challenge to most of our programs. And therefore, we really need to support and scale up intervention strategies, particularly to the young people, where they've got high rates of viral load failure. The data from the population study that we conducted 2015-2016 showed that the young people actually have lower levels of viral load suppression, and therefore we really need to target those kind of populations.
Thank you. And Wame, what should we do to increase access to second, third line and address some of the issues that Tsitsi presented?
Yeah, I think we need to take a moment to actually fix what's not working at the moment. Things like routine viral load testing, if you're talking about switching, is quite a critical aspect of that. And if you look at the data that has been provided in terms of where we stand with viral suppression rates and also our VLT testing, we're doing not very well in comparison to the other two pillars. So that's still something that we're struggling with and we need to fix. There are still problems with, as mentioned before, the way that the service is being offered, the access issues around it as well, and even in terms of the results, the turnaround time for results. So until we deal with some of that, we will still have some of the challenges with switching. The other issue, again, not to beat on a dead horse, but honestly, the issue of drug stockouts is an element of frustration, specifically for us as communities. We see it constantly as a conversation that is happening globally. Many recipients of care are being forced to take treatment holidays because of the stockouts, and that's the reality that's happening on the ground, and something that we need to just recently we got an email from an activist in Fiji who's dealing with stockouts. Same thing that's happening in Argentina. There's so many countries that are reporting drug stockouts. So it's a growing issue, again, when we talk about what do we need to fix in order to shift to second and third line. The other issue is around the drug affordability and also diagnosis as well. We need to explore how we can have better costs for the drugs when we look at second and third line as well. And I think the last point in terms of what do we need to fix to increase access to second and third line is how we engage with communities around treatment as well. We take for granted that treatment education is one of the critical building blocks in making sure that issues of adherence and also having recipients of care be engaged in terms of understanding the science of the drugs that they're taking, even just the names, very basic information. What kind of drugs are you taking? What is the name of your medication? Why is it important? How does it benefit me as someone who's taking the medication? It's important conversations that we need to be having with people who are receiving the care. So until those 3 or 4 points are actually dealt with, I think we can talk about successful switches as well to second and third line regimens.
I'm gonna follow up on what you just said. I remember. When we started to talk about treatment and starting with a scale-up of treatment, there was a lot of noise from communities to trying to support communities. There were a lot of peer-to-peer programs. What do you see those programs are at now? Do you think that they're survived, that need to be reinvigorated? As we are talking in this conference, I think we're going to hear a lot about the reinvigorate prevention, whether we need to go back to some of the elements that were on the response in the early days of a treatment scale-up.
And I think that's part of the... Okay, I think that's part of the frustration with when we talk about the transition in funding, is that those are some of the programs that are actually failing to get support adequate support, community system strengthening, empowerment of communities to be able to engage in service delivery. So when you look at the differentiated service delivery models, how are we using the communities to engage dialogue with recipients of care and bring them into the conversation around care and treatment as well? So unfortunately, that is one of the frustrations. This coming from a community activist meeting this morning. There's a feeling of helplessness because it's almost becoming like a broken record. These are the problems that we keep encountering as communities. We're not being engaged. We're not being put at the center of making decisions around what is appropriate in terms of healthcare service delivery. So there are opportunities. I think the funding is also not shifting in that direction. We're seeing more and more decrease in that level of support, and that's something that we do need to scale up and think very carefully about what it means. Advocacy and community system strengthening is a very difficult thing to fund because the expectation is that the results are seen immediate, and this is something that we have to invest in communities over time. It's not a one-hit wonder. It's something that requires a lot of technical, financial support in order to get the gains that we would like to see over time.
Yeah. And Daouda, what is your take and what you think about the differentiated service delivery and how you see that affecting or not the delivery of care over time?
Yeah, I think from a West African perspective, because we just held meeting with 18 activists from West Africa, coming from 16 countries from West Africa, and West and Central Africa, and the situation is more or less the same. So just to remember that, to remind you that West Africa is lagging behind. The figures that we have on access to testing, access to treatment, and viral suppression, globally we are at 18% in the region, which is totally unacceptable. But it is, you can correlate that with the level of investment on the AIDS response. Mm-hmm. So we are talking about decrease of international investment on HIV. It means that we are putting more responsibility on the country to invest, but to prioritize. If you ask a government to prioritize which investment they will be doing, of course, I think they would not say, number one priority in investing on community system. And if you don't invest on community system to deliver services, just information on treatment, access to those who are marginalized, access to a monitoring system of the quality and the resistance of treatment. And then we've talked a lot 15 years ago about treatment preparedness, treatment education. I think more than ever, this is an issue that we are facing while we're talking about drug resistance. And the sad side of it is these are the activities that are less funded in a country that is in a situation of prioritizing where to put the investment. So to me, the situation is even worrisome in a way that when a country has to cut, they will cut first where they don't have control. But the position of the government is that, okay, we know, we recognize the importance of community system, the community work, but we don't have control on what the community are doing. So the key issue is not whether you have control on something or not. The key issue is whether we are delivering services, there are qualitative services that are reaching those who are unreachable through the same paradigm, same old system in delivering care, services, which is the normal health systems. So, to me, these are the main issue that we are facing. The other thing is that when we talk about getting the services out there to people who are really on need, who are positive, we are talking about having community professionals to get there. The situation that we are facing with is that many of the community organizations, CBOs, NGOs are closing down because of lack of funding. And this is a real problem that we need to talk about. And then we will see a lot of more resistance, we'll see less access to testing, and of course, nobody will be there to monitor whether there are stock out or not, and nobody will be there to hold accountable our government. Because we need strong civil society to hold accountable our government, to invest more and not rely always on external donors. Because when the government has an interest on, political elections and keeping their chair, they can invest on it. But while it comes to invest on citizens' health and the quality of it, so you need a strong civil society to be at their back to say this is a priority for the country, this is a priority for the health of the citizens. So that's why the fact that there is a decrease for civil society organizations to get access to the funding, it worries me a lot. And then the situation that we've been discussing will get worse if we don't do anything about it.
Thank you. I think we are in a very particular time in our. We're back in Amsterdam after 26 years. Treatment was far away from being a reality 26 years ago. We know it's a reality now. Is 60% of people on treatment, but clearly issues around quality, sustainability, maintaining people alive is still a big issue that we haven't resolved, and we have a long way to go. You talk from the community perspective, and I want to take it now back to Tsitsi and from our health systems, or from the Ministry of Health. One of the main issues is systems that are overwhelmed by the population. So how is Zimbabwe coping with it?
All right, thank you for that question. Indeed, with the increase in the number of people that are accessing services, 1.1 million on treatment, we had to come up with some coping mechanisms in a way. So we've gone on a massive decentralization drive in the last couple of years, whereby starting from just 5 centralized centers to almost 95% of all health facilities in the country, where patients can access services closest to where they live. So this has really helped in terms of sharing, distributing the work across the facilities. But what we've seen is that there was no a corresponding shift in terms of resources in that direction. The resources remained behind. And therefore you find that at the lowest level, at the primary care level, that's where we see 80% of all the people living with HIV on ART. And yet, that's where you have the least number of human resources, the least quality of human resources. There are no doctors there. The nurses, they're lower-level sort of cadres at those facilities, and therefore they have to manage long queues of patients. So what you visit some hospitals, you find that they'll tell you, oh, we used to be very busy with so many clients here, but now they've all gone to the clinics. So there's need for that now to rethink. I remember at some places they say, no, we cannot take any more patients. We have enough numbers. Let them stay where they are. So we're at that point whereby we need to reflect and be able to allocate resources to match with the distribution of patients in those areas. The other opportunity that we have and that we're pursuing is the adoption of the differentiated service delivery policy a couple of years ago, which has really enabled us to let the patients that are stable on treatment to be seen less frequently, and therefore that has really helped us to create some space for health workers to really manage the other patients. And as more facilities take on board those kind of models, we are seeing a shift in terms of less number of clients that are seen, the volumes of patients that have to be seen. And we had to revamp our supply chain systems and all that in order to manage patients at those levels and making sure that they are able to get their medicines using the multi-month prescriptions. Another coping strategy is really to shift certain tasks to lower level primary counselors. So we do have primary counselors, we do have primary care nurses at those lowest levels, and we also have expert clients. We've got other community cadres that work around a health center to support care for people living with HIV. What we are seeing is that the support that is there is heavily supported by external support, external donors. And therefore, there's sometimes lack of standardization in terms of how we provide those services. Although in the guidelines, it's very clear in terms of the roles and responsibilities, but there's a myriad of community cadres. Some of them are funded by different partners and doing different things. So we need to find a way of harmonizing and understand what they're doing, coordinate them, making sure that people are actually receiving the care according to what is stipulated. And the other issue is of sustainability, when you rely on partner X and Y to support the community cadres. So beyond the clinics, we've pushed services into the community with the DSDs and others, but resources are not necessarily getting there. So that is a challenge that we need to resolve. And also the tools for management. I visited some facilities whereby people living with HIV were already sensitized about DSDs, even more than the nurses at the clinic. The nurses were not clear how are they going to decide who goes on this model and that model, you know. And even the tools, they were actually hesitant because they were saying we are going to lose patients. They need to see the patients more often and manage. And so we have come up with, we are adapting tools so that we are able to actually track patients even in the community. Even if they have to come for fast-track refills for different types of services, we are able to actually monitor them and keep a track and know that these people are actually indeed alive and on treatment. So another way of coping is like, we're talking about the conversation around universal health coverage and other things, and the fear that, okay, HIV funding might now go into other areas or things like that. But we're seeing that since 80% of people are already receiving care at the lowest level, services are fully integrated at those levels. So there's full integration. And therefore, TB HIV, for example, is being offered in a collaborative way. And there are opportunities to even provide NCDs and HIV integrated at that level. So there's a lot of integration already. And we've seen funding that comes from the Global Fund, for instance, that has really supported health systems, supporting M&E, you know, with DHIS2, and even personnel, human resources are being supported, and therefore we're seeing health systems that are being strengthened. If you look at supply chain management systems are being strengthened and all that. So these are opportunities from the HIV experience and resources that support health system to be able to be a platform that can deliver HIV services. So there are those kind of opportunities that we are currently seeing.
Thank you. Francois, do you want to say something about what is the situation in South Africa? Is that decentralization happening? To how effective is, how well it's been implemented?
The vast majority of patients in South Africa, you must remember that South Africa has far more doctors and nurses than practically anyone else. In fact, if you look at the WHO critical staffing health lists, we don't actually feature. As I said before, we tend to use our resources pretty badly, but we have got the situation where well over 90% of patients who are initiated on ARVs now are initiated by nurses, and most of the care happens within primary healthcare sites, the vast majority of it. Having said that, I think there's some important questions when we start looking at our data, and one of the things that we worried about was as sites got more decentralized, we thought the big sites would get busy, that there would be enough sufficient time spent on adherence, that, you know, the very, very busy, particularly the urban sites where we have several thousand patients sometimes in the site, that the attention to care would fall down, adherence would fall down. And in fact, we saw exactly the opposite. If you look at that, we've got very good viral load data by clinic, and you see this consistent correlation where the bigger the clinic is, the more HIV patients are in the clinic, the greater the suppression rate. So you'll go into central Johannesburg and routinely find suppression rates over 90%. You go into rural Eastern Cape where there's 200 patients in the clinic and the suppression rates will be in the 60s. And I think there's some real lessons there. And I do sometimes worry that this mass drive towards non-verticalized service and integrated services means we regress to the mean, which is not a great mean. And I worked in the diabetes world before I came to HIV, and patients who were 60% adherent on their antihypertensive or diabetic clinics were heroes, while in an HIV clinic, those patients are just prime candidates for virological and clinical failure. So I think there's a lot to be learned from these various things that are not as intuitive as we'd like to think. I am heartened by the fact that some of these, what I think is happening in these larger clinics is actually patients are supporting each other. Plus, the healthcare workers do get conversant, and we know that amongst doctors, the more you see of a certain condition, the better you get at it, and the better your outcomes are. We see that whether you're a colorectal surgeon in America or whether you're a diabetic doctor working in Kampala, the experience brings experience, and your patients fare better. And I think we do need to think hard before we start rushing towards decentralization, because it's often code for cut costs. We dump people in primary care where we dump everything on the community where we dump everything, and the consequence of that might be that we actually lose virological control at a period when we, as Mark said earlier, where we might actually lose the war against HIV.
Thank you. Thank you. I'm going to open the floor now for questions. Meg will need to leave in about 10 minutes. The rest of the panelists will all stay until 2:30. But if you have any particular questions for Meg, just do it now. And obviously open a question for everyone as well. Yeah.
Questions and comments should be coming up on the screens.
Because you could use your application for the questions.
If you
Yeah.
want a question or a comment, type it in, and here's the first set. And you should be able to read those, Alex.
Okay. I don't have my glasses. But there are issues around integrating AIDS services into universal healthcare, critical for both financial and political sustainability. On treatment, there is an urgency with treatment options of young children below 3 years of age. What we are doing. Treatment quality can erode slowly, so you don't see the harm until it's too late. Good point. How do stockouts and a lack of support services affect decisions about early initiation? And Francois, lessons learned in South Africa. We need to bring in the economists to build our business case. We need more data about the characteristics of people who develop resistance. How far should health system go in terms of relying on community health workers? Is this an optimum for it? So there are more questions, I think, but just if people wanted to comment on some of these questions, open the floor, sorry.
I think there's an opportunity. One of the questions there is how we need more data from characteristics of people who develop resistance. Probably 90% of our patients need no support. They want their tablets, they want to get on with their lives, they want to swallow them. The problem is that 10% changes. You might lose your job, and your relationship might break down. You might have problems with alcohol, and these things transition from one to the other. So the people who need support change year on year. What we have realized from the resistance data from South Africa, and Tsitsi kind of alluded to this, is that our NNRTI resistance level is above that magical 10% WHO threshold. When you tease it out, though, the vast majority of those cases are people who are returning to care. So they've fallen off the ARV program and they're coming back. They're not the people who are absolutely antiretroviral naive. If we had a way of identifying those people, we'd be able to identify at least a good chunk of people who we could support, people who've fallen off the program. By the time they're coming to us, there must be a reason for why they're getting there, and trying to work out packages of nuance where the 80% who don't need anything, the 10% who might be transitioning in and out, and 10% who really need some help. It would be a much more better use of healthcare resources to be able to focus on that rather than treating all 100% of the patients in exactly the same way.
before Meg leaves.
Oh, okay.
Yeah.
Thank you. I see a few that I could answer from the perspective of what we're doing at the global level. It says there's an urgency with treatment options for young children below the age of 3. What are we doing? And I would have to say that there are quite a few partners who have really been working on what we call treatment optimization, or improving the pipeline and even the R&D for treatment for children and for infants and neonates. And there is now a group of people who've been working on sort of setting out what are all the priorities and how can we fast track the priorities around the drugs that we need, how to get them developed, and then through regulatory and then utilized in the places that they're needed. So I would just make another shameless plug. There's a session tomorrow morning, I think it's at 10:15, and it's called the Global Accelerator for Pediatric Formulations. And it's really talking about what are the mechanisms, because pediatrics has been slow because they usually wait for the trials in adults and then decide to do the dosing down for children. And that takes time, and then and so now we're trying to accelerate that process. And I wanted to say also about what are the recommendations with respect to rollout of dolutegravir in low and middle income countries. Again, another shameless plug. Tomorrow at 12:30. But WHO, right around the same time that all these issues related to birth defects were shared with us, we were also in the process of doing a guideline update. And we see that there is going to be a role for dolutegravir use. And I think tomorrow what we'll be able to do is share with you what the guideline development group came up with and what the recommendations they made to WHO on how to do that. And there will be a role, and I think there will be a definite role certainly for children and adolescents, which is exciting. And I think if there was one other one, the PrEP scale-up. Well, that challenge is, if we do PrEP aggressively, is that going to make our HIV DOR worse? Well, one thing we are doing with HIV drug resistance is setting up surveillance and a system of how one might be able to follow for drug resistance related to or secondary to PrEP and poor adherence in PrEP. And I think it's going to be a very rare event. And time will tell, but surveillance is the approach to be able to identify if we do start to see any kind of challenge in that area. But we also see that PrEP is also very good. Today I was at a great session this morning where PrEP being used for women who are pregnant, and there were some great results. And so I think that we shouldn't be afraid of using PrEP because of drug resistance necessarily. It's sort of like holding back your drugs until somebody's really, really sick. I think we can utilize these, but we then have to be able to measure it and understand it and be aware of if there's a red flag warning that we need to shift gears. That would be my approach, but there may be others who would have a different approach. And I would have to say I'm going to have to apologize.
Thank you. Thank you very much.
I was asked to pinch hit for somebody who's ill, so I'm headed off to another session. Thank you very much.
You're welcome. Thank you very much. Wame.
Thank you. I think there's a question here around treatment quality. Can erode slowly. So if we don't see the harm until it's too late. I think that's really important, and I think we need to come up with better ways of how we can actually track and also share the data on quality. A lot of it is really looking at the qualitative data and really beginning to collect it, having more conversations with communities in terms of what are we seeing, what's going wrong, and how can we fix it. So I think we need to figure out how we can actually have more conversations around quality while we're tracking the 1990 objectives, which is fine. We need to have more conversations around what that picture looks like internally as well. And in terms of domestic resourcing, I think it's important to stress that that's necessary in every country that we scale up domestic resourcing, but we need to take it scale by scale in terms of what is feasible within the national governments and budgets. And also there's a reality in terms of what right now external funding is supporting in terms of countries as well. And really taking introspect, key population programming is one of the programs that are really heavily funded by external donors right now in many countries. And the shift of external funding from those countries does compromise the ability for us to be able to look at key population programming in terms of service delivery, in terms of advocacy, etc. So I think it needs to be done carefully, and I think it needs to be done with a lot of thought and collaboration with communities in terms of how do we scale up, some DSD models and other models as well, while we're making the shift to domestic resourcing and negotiating with governments, because it's not an easy conversation to have. And yet, those are the subpopulations that are highly compromised in terms of HIV. So we really need to have that discussion very carefully.
Thank you. Daouda, yeah.
Yeah, I wanted to reflect on the integration of HIV services into universal health coverage. I know this is a hot topic now, and the general feeling is that we should go away from vertical program toward a more integrated program. I think we have to be very careful not to lose the focus and the gain that we have been able to sustain through the intensive, and the panel this morning said about the intensive focus on where the most marginalized people. Like if we integrate HIV into universal health coverage, then of course, which of our African government, I can say it as an African would prioritize key population within the universal health coverage? None of them, because it's sensitive for them, it's difficult, it can sometimes, because of the pressure they're receiving from religious leaders, traditional leaders, and ideology, it's highly political against them. So they wouldn't take that risk. So they will either dilute it into the global universal health coverage package. So you have to be very careful and take time to reflect on what are the modality and how best we can do it. So I have not heard that much on what is the best engineering to make it happen, so that we can lose the focus. The other thing is that I haven't seen in universal health coverage the human right dimension. Mm-hmm. It's not there at all. It's about, as you say here, you can financial sustainability or reinforcing the health system. But these things are not only technical. Mm-hmm. It's about people's life and people's dignity, and people's overcoming barriers that are returning people from accessing to those services. If those barriers remain, even with universal coverage nationwide implemented, the most vulnerable people will not access those services, being universal health coverage or HIV or more integrated co-infection program. So we have to be very careful. We have made significant progress in terms of investing on accessing to services for key population. Or we are also working toward reducing stigma and discrimination, respecting the right of people, including right to health. So we should not go reverse while we are coming with a new paradigm in terms of access to health for all, which is a good goal, but we have to reflect on how do we go about it.
Thank you. Tsitsi.
Thank you. I just want to comment on two issues. Regarding domestic resources, it's very critical for governments to take care of the health of its people, and therefore there's need for us to really scale up and find the money within countries to support our responses. A few months ago, we started a new levy, which is called the health levy. In addition to the AIDS levy that we have, In Zimbabwe, we also introduced a new levy, which is the health levy, where there are some deductions that are made from airtime, because there are so many mobile phone users. So some deductions are made, and we've been able to leverage on those resources to buy essential medicines, and therefore also including drugs for opportunistic infection. So there are opportunities for us to really raise the domestic resources. And the Global Fund policy on counterpart financing also helps to make it a requirement for governments to commit resources to the HIV response. And then the issue around how far should health systems go in terms of relying on community health workers? We have to work hand in hand together with the community health workers. In fact, they are an extension to the health system in a way. And therefore, we need to make sure that they are supported in a sustainable way. We need to make sure that we build the capacity of community health workers to provide the services that they're supposed to be provided, and to ensure that they are remunerated accordingly. We need to provide them the tools for them to be able to do the work, and therefore it's something that we need to look at and work together, alongside with community health workers.
Thank you very much. I think we're coming almost to the end of this panel, and I want to thank all of you for very interesting observations and contributions. I think they deserve a round of applause. And I also want to thank the Joep Lange Institute for giving us the opportunity to start putting issues on the table before the conference. I think this has been very useful to start sort of teasing out what are the issues that we are facing in terms of access to treatment, and not just in terms of the access in itself and the health system, how this health system is structured to deal with the current issues, but also issues around quality and the perceptions of communities of what is lagging, where things are not still there, and how we continue in our response to strengthen those areas. So thank you also to the Institute for this opportunity.
Thank you all. Thank you very, very much.